Welcome, everyone. We'll get started in just a minute.
So get away from the pain, ease my mind, yeah. But we're estranged, yeah. No, that we're better off leaving us behind, yeah.
We're welcoming everybody. We're just going to take 30 more seconds. All right, well, as people come in, I just want to welcome everyone to our final Health Equity Action Time. And this is our critical final session for this series that's been focused on mental health. And today we're moving from promise to practice and creating a roadmap together for the future. So we'll review the agenda. Cassandra can go to the next slide. So we are just so excited to welcome you to the culmination of our three-part virtual Health Equity Action Time series, where we've come together as a community to foster learning, connection, and concrete action to strengthen the system of care for children and adolescents and improve their well-being and mental health outcomes. And it's June and there's so much going on and it's summer, so I just appreciate everyone taking the time to join us today. We're recording because I know a lot of people have registered who also cannot be here today and would really are interested in seeing the recording afterwards. So today we'll have the opportunity to converse with some really critical partners of ours, including our local managed care plans, school-based mental health, and the UCSF health system. And that's really, I want to thank participants in the prior sessions who've really called out the desire to hear more from our key partners. And so we heard you, and we're excited for today. And at the end, perhaps the most important activity of the entire series, we'll have breakout groups to identify our priorities in the next 1 to 3 years and identify next steps. The next slide. So if everyone can take a nice deep breath and just ground yourselves in our session today. And we want to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. And we pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place, the land that UCSF sits upon, their home. We are proud to continue their tradition of coming together and growing as a community. And we thank the Ramaytush Ohlone community for their stewardship and support. And we look forward to strengthening our ties as we continue our relationship of mutual respect and understanding. Next slide. I also, on behalf of all of us in the committee, we really want to acknowledge the amazing commitment and expertise of our planning committee members who are listed here. We've been meeting twice a month for almost a year now, and just really appreciate all that they've brought to the series. Slide. So we want to take just a brief moment to recap the first two sessions, really because at the end, when we think about what the next action steps are, there are some activities that we did in the first two sessions that will help ground us in what people brainstormed about before. So just as a reminder, in April, our first session is to create space for critical dialogue and provide a landscape analysis to better understand the current state of what happens to children and adolescents with mental health needs across UCSF sites and services. And this is really an important first step for us to have a common foundation from which we could engage in meaningful discussions for the next session, sessions 2 and now 3. You'll find the recordings and chapter tabs breaking down session 1 available on the HEAT website. So if you search in the search engine UCSF Health Equity Action Time, you'll find it. You'll also find it via the barcode, which is in the slide. So we asked at the end of that session, what is one goal you hope UCSF, VSFG will accomplish in the next 1 to 3 years to better support the mental health and well-being of children, adolescents, and their families? And there were 5 key themes that emerged from the Jamboard activity. The importance of integrated care coordination, the importance of grounding our work in diversity, equity, and inclusion, our collective and institutional role as powerful voices and advocates for systems change, and our role as an employer and education institution in building capacity. Next slide. The goal of session 2 is to meet with leaders who are re-envisioning California systems of care and take a deep dive into unprecedented state reform around behavioral and mental health. And as we think about priorities and concrete next steps today, again, we wanted to highlight the key takeaways from the breakout groups we had based on health systems. So we had a breakout group of UCSF Health, and then breakout groups of San Francisco County and Alameda County. And some of the themes that came, that we took away from those breakout groups was 1, a desire for collaboration across UCSF departments and divisions, breaking down those silos to disseminate knowledge we gain, such as like new billing codes or processes, so that we could join forces and also join forces to apply for things like new funding. And also people highlighted the need to protect time to do this collaborative planning. And suggested to create subgroups, perhaps by developmental stage or age, for example, since needs may differ across the different stages. There is a strong interest in partnering with schools, which we'll hear from more later today. I'm super excited about that, and creating school-based supportive infrastructure to help address mental health needs. And then also you'll see a theme around partnering. So partnering with health systems, we'll also hear from today, and larger CBOs. In particular, they were thinking about partnerships to support smaller CBOs, community-based organizations, to support them becoming Medicaid providers. For example, creating a technical assistance hub or learning community with coaching, so that smaller community-based organizations could have the resources to become a Medicaid provider and implement some of the funding that's coming down from the state to serve as care coordination in conjunction and in partnership with us. Those are things that we heard from some of our community-based organizations. And then also breaking down data silos. What are key performance measures that cross systems can agree on and be accountable for? How do we advocate for shared data across systems like Alameda's whole person care? To build one database, and again, the highlighting of collaborating with schools and other service sectors like juvenile justice to identify concrete funding opportunities and improve coordination of mental health care. So those are just some things to hold from our prior sessions that we should carry forward into this last session, especially as we think about critical next steps in our priorities. Next slide, please. So today, our goal is to consolidate what we've learned and identify concrete steps we must take as providers, policy and system leaders, and advocates to create a shared roadmap to improve and increase access to the mental and behavioral health services for children and families. That is the whole reason we pulled the series together, and I'm really excited to see what you all have to say, and I appreciate all the expertise here today with us. Next slide, please. So now we'll hear from Skye Timmons. Their pronouns are they, them, theirs. Skye is a project coordinator with the UCSF Center for Child and Community Health, and they oversee health education at UCSF Benioff Children's Hospital, Oakland's 2 school-based health centers. Since February 2020, during the pandemic, the school-based health education team has implemented health education at the Chappelle Hayes Health Center at McClung High School and Youth Uprising Castlemont Health Center serving Castlemont High School, Rudsdale High School Technology Academy, and Leadership Public School in Oakland. The school-based health educators work directly with youth and schools to deliver health education, peer health education programming, and case management in schools and the school-based health centers. Their work is grounded in health equity, anti-racism, and LGBTQ plus affirming care with youth as partners and leaders of design and delivery. It's really such a great model. Skye is with us today to ground us in the importance of building trust and meeting young people where they're at to support students' mental health and well-being. Thank you so much, Skye.
Thank you so much for that introduction. Thank you all for having me. It's an honor to be in this community and in this conversation. So really in talking about relationships with young people, I just want to center it on something that I've learned from my mentor, Sauntoy Trotter, that relationships are imperative to the work that we do. So I've really taken that to heart, and we've really worked on our health ed team to center relationship with young people, with school staff, with teachers, in order to best create healing-centered health ed practices. So I'd like to offer 2 strategies that we've learned in health education at school based here in Oakland. One of those is really consistently showing up as learning partners in youth spaces with compassion and cultural humility. This is especially imperative as a white educator on predominantly Black, African American, and Latinx spaces. And one way that we've really worked to show up as learning partners is being very much in constant communication and partnership with our school staff. So we were asked by the Castlemont High School Health Equity Academy to pilot a public health advocacy class as part of the 11th grade curricula this past year. So myself and co-educator Sarah Lee worked with our behavioral health team to implement evidence-based, culturally responsive content on trauma, ACEs, and resiliency in the classrooms. We spent an entire semester learning with students how stress impacts the body, how trauma impacts the body, and really working with young people to understand the protective factors that they have and the resources that they already have in order to keep deepening this net of support. We work directly with Karina Almendares, who's a brilliant medical social worker at the Youth Uprising Castlemont Health Center. And she came into the classroom and offered a workshop on how to decolonize mental health care, how to really ground into cultural traditions and familial traditions of mental health, and offered students an aromatherapy practice where they got to pick their own dried flowers and herbs, create their own pouches of aromatherapy, and learned how to breathe in those smells to really activate and get into their parasympathetic nervous system, which is what they learned in the class. And we were able from that to really connect young people to mental health services with Karina, because they met her, they knew her. And I was like, hey, do you want therapy? They're like, okay, Karina, okay, cool, we'll go over. So it was just really transformational having that medical social worker in the class so that young people knew her, and trusted that we could connect to services. And I think in really ending with that class was young people ended the semester, their final project was to create a mental health public service announcement with everything that they had learned from the class. And each young person created a poster calling to action, something around mental health with resources. And we now have those on view at the health center. It was very exciting. So again, this was really just us showing up as learning partners, asking school, what do you need? And learning from young people, how do we destigmatize mental health? How do we get young people connected to care? And I think a second strategy we've really learned is investing in young people as leaders and really provide training on transferable skills. Malia Naps and Tony Coulter are brilliant young people who were with us in the first session. They really talked about this need for clinicians, also a need for Black and Brown mental health clinicians. We've taken it really seriously to really invest in the mental health career pipeline. I'd like to call out Baja Jordan, our health education coordinator. She is moving to Atlanta today to start her master's in public health at Emory University. So we're thrilled for Baja. And Baja just did a phenomenal job centering the needs of youth at McClung High School. She worked with a group of 12 youth leaders on a youth wellness advisory board. They met weekly. They created a needs assessment over Google Forms and asked students, teachers, and school staff just the impacts of COVID-19. And these youth leaders were really surprised to find just how much burnout there was, not only in students, but in school staff and student teachers. So from that needs assessment, the young people worked with Baja and learned how to put on a community-wide event. They named the event Chamomile and Chill. They created this beautiful event during lunchtime at McClymonds High School. They had therapy dogs, they had community organizations, a raffle, therapists were there, community partners, and they strategically planned the event during Black History Month, as this camp is predominantly Black African American community, really to center Black joy and Black healing. So just another job of really investing in youth leaders to show us, what do you need and how can we provide you skills to be able to create some of these change in community. So that is a ramble and an honor and a joy. So thank you for having me and for this community's commitment to advancing health equity.
Wow. Thank you so much, Skye, and for representing the youth. Just so inspiring and really a great way to plant us solidly in why we're doing all of this. Thank you for grounding us in that. So I'm going to take a deep breath and as we kind of just absorb all that Skye shared with us, move us into our first panel. So we have our a panel with our local health plan representatives, and I just again want to thank them for partnering with many of us over many years, actually, as we really try and reimagine how our systems can work together to best provide care. So our panel will be moderated by Kate Margolis, who's Director of the Division of Integrated Behavioral Health at VSFG. And joining Kate on the panel, we have Vanessa Aranda, Children and Families Program Manager from San Francisco Health Plan. From Anthem, we have Carissa Avalos, Regional Program Manager, Dennis McIntyre, who's the Medical Director, and Alicia Pimentel, who's the Program Manager of California Medicaid Health Plan North. So Kate, I'll hand it off to you. I wanted to get you 2 more minutes, and so we have until 1:50 for the panel. I'm just really excited about this. Thank you.
Thank you so much, Anda, and thank you everybody for joining us today. It's really, really wonderful to be able to spend a little bit of more focused time with our plans and Anthem and San Francisco Health Plan. We are a two-plan county in San Francisco, and so both share the benefits, issuing the benefits for Medi-Cal patients in San Francisco. I'd like to just start off with a little bit of level setting. And I'd like to go to Dr. McIntyre and to Carissa to see if you could help us with some basic level setting. If you could tell us about the role of managed care plans as it relates to children and families. Could you help us understand some of the basic concepts of MCP responsibilities and current systems around things like general case management, enhanced care management, and then also the non-specialty mental health services benefit versus specialty mental health?
Well, it's a mouthful. I'm going to just jump over and ask Carissa if she wouldn't mind starting.
Sure, sounds good. Good afternoon, everyone. Like Kate mentioned, my name is Carissa Avalos. I work on Anthem's Medicaid side, and my lane right now is CalAIM. I'm working on both ECM and community support networks, as well as just overall county and community initiatives that bring forward care coordination. So, okay, Kate, sorry, back to your question. It is a lot. So let's see, where to start. I mean, maybe let me break it down. I'm gonna pull up the questions, or do you mind asking the very first part of your question first?
Absolutely. So we're talking about just some of the basic concepts, knowing that there's been a big focus related to children and families and expansion of things like care coordination. So talking about sort of the basic obligation that MCPs have related to care coordination and general case management, adding in then what we know about ECM, enhanced care management, that's coming. And then finally, the difference between non-specialty mental health and specialty as managed by the MCPs and specialty mental health.
Okay, sounds good. Okay, so let's tackle the first piece. So care coordination. Yeah, so as many of you know, the state is looking to the managed care plans to really play a greater role and have a greater responsibility in ensuring care coordination across all of the services of care that we are responsible for providing our Medicaid members. And so in the past, it looked like a number of things, and now most on the forefront of my mind is CalAIM and the state's attempt to use CalAIM as sort of like the vessel to bridging a bunch of services that were always under care coordination sort of services under Medicaid, and also expanding to social services that were not previously Medicaid services, and now we're bringing them into the network and making them Medicaid services in the goal of making one unified delivery care infrastructure system to be able to support all of our members navigating the services they need, and to have really a point person to make sure that they are able to reach and access these services they need. Because what's the point of us, launching 14 new community support services if nobody knows how to access them or that they are eligible and available to people? So one of the state's ways of really enforcing the managed care plans to sort of dive in head first in ensuring care coordination is through CalAIM, and there's a couple of levers, maybe some carrots and some sticks that the state is using to get managed care plans like San Francisco Health Plan and Anthem to really hit the ground running and expanding the services that are offered through enhanced care management and the new community support services, the 14 services that are now covered under Medicaid. And so I don't know how much detail would be helpful to share now, Kate. So just feel free to reel me in, because this can get pretty big pretty fast. But essentially the state's using the managed care plans as sort of the conduit to ensure that this is happening. And so our responsibility is to go out into the community and make sure that if we haven't already been working with an agency that is doing care coordination, especially doing care coordination with some of the most vulnerable populations in our community, that if we haven't already been doing that work, then they want to make sure that we're doing that work now. And so that looks like us helping providers, whether it's a traditional Medicaid provider or a community-based organization, helping them get ready to start offering more expansive, more high touch point case management services, as well as doing things like billing for Medicaid, which might be brand new for some of these community-based organizations, as well as training, doing some TA for organizations that do support these populations of focus, but maybe don't do the level of care management or case management that the state is looking to see them at. And so, training providers to get to that level so that they are prepared to offer enhanced care management services. And the other arm of CalAIM is community support. So things like housing services, meals, nutritionally supportive food and meals, asthma remediation, environmental accessibility, short-term post-hospitalization. All of these are now under community supports, and another opportunity for us to make sure that if we're able to connect with an individual that has high touch point case management needs, that we're also able to successfully route them to the other services that exist in the community that might stabilize them even further. So really it's about building a broad spiderweb network, and hopefully decreasing the barriers for our members to be able to navigate that journey.
Yeah, and just to add to that, Kate, this is Alicia with Anthem, and Carissa, that was a really good overview. I would say too, just to kind of piggyback off of what she was saying and then kind of talk about the specialty mental health piece that you had mentioned. We do have an entire team of case management, nurses, we have doctors, we have community health workers that work within Anthem to make sure that they're not only working on the CalAIM piece like Carissa mentioned, but we are also, just making sure that our case management team works closely with our public health departments, our behavioral health departments. They work closely together. So our physical health case managers work very closely with our behavioral health case management teams. I thought I saw Vanessa on the call somewhere here from San Francisco Health Plan. We work closely with our other managed care plan partners to make sure that they know about what's going on within our organization and vice versa. And then as it in regards to the specialty mental health piece, we know that the county mental health department is plays a huge role in serving our children, our members, even if they are not specialty mental health, even if they are maybe on the mild to moderate spectrum, they may show up at, the county behavioral health department. So we make sure that we're working very closely with our county mental health department teams. And I know we'll probably talk a little bit more about this in a later discussion for our student behavioral health program that's coming up, along with what Carissa mentioned around, the CalAIM piece. But we're responsible for the mild to moderate piece. And, we do not, we direct contract with our providers. There's no prior authorization for our members to be seen within any of the counties that we service. We have 29 counties throughout the state of California, but I know we're talking about the Bay Area here. So Alameda, San Francisco, Contra Costa, Santa Clara. Our members can look up a provider within their within our network, and they can be seen with no prior authorization. There's no limit on how many times they can be seen by a provider. We have telehealth services on the mild to moderate side for our members to be able to access services. And then again, like I mentioned previously, we work very closely with our county mental health providers who, sometimes, members, may be mild to moderate, and then they may escalate to specialty mental health or vice versa, need to be stepped down. So we make sure that we are in direct contact, and our case management teams are available to provide those warm handoffs and, set up things like transportation if they need rides to get to a provider, if they need rides to get to, their specialty mental health provider, things like that. So, we work very closely with, not only our community-based organizations, not only our other, MCPs within the counties that we service, but also our county public health and behavioral health departments to make sure that our members are getting the services that they need.
Great.
Kate, could I make a few comments?
Please do.
Point? Hello, everybody. My name is Dennis McIntyre. You heard about me a minute ago. I'm one of the medical directors for Anthem. There's about 10 of us, so it's not like I'm the big cheese of anything. I always like to set that straight with audiences. I don't have as much power as you might think, so you got to clarify the title. In any event, let me really sincerely thank you all for the great work you do, as well as for inviting us to be part of this 3-part initiative that you took. And it's been very impressive. You're doing a great task for our communities. And again, want to thank you for asking us to participate. That said, I'd like to make just a couple of comments, and I'm mindful of the time, so I'll be brief, and we can perhaps get into these later in the discussion and some of the strategies and tactics that people might want to discuss in more detail. But getting back to the old issue of setting context, as we try to navigate ourselves through this tremendously complicated thing we call the American healthcare system, I've found it often helps me stay centered and grounded if I think of a couple of issues to keep in the back of my mind all the time. And some of these are related to who our audiences are. Who are the audiences we're addressing as we do this work? And I've called something the 5 Ps. I refer to it as patients, providers, policymakers, politicians, and payers. And the way I see the system, a lot of people would argue with even calling what we have a system. Speaking just for myself, I would agree. I don't know if we've earned our stripes yet to call what we have in America. I'm not talking about San Francisco. I'm not talking about California. I'm talking about our nation and how our nation really has not yet reached healthcare system status. Rather, we have a terribly complicated, as you know, set of hundreds and hundreds, literally, of microsystems that don't interact terribly well. So I always try to keep that in the back of my mind. And when we're discussing issues, I always try to ask myself, what would these 5P audiences think? I imagine them as a set of intersecting Venn diagrams with various degrees of intersection among them. So, and the second thing I like to think of are what are some of the tools or the assets that we can use from elsewhere to keep ourselves, on a steady course and focused. And in that arena, I think of 3 or 4 key issues, 3 products, 3 initiatives, whatever you want to call it. But number 1 would be CalAIM and the Department of Healthcare Services. Number 2, NCQA, National Committee for Quality Assurance. Number 3, HEDIS. HEDIS is a byproduct or a child of NCQA. They've both been around for a long time. They have proven track records in the issue of quality. So when we're talking about quality, frankly, there's no one who does it better than NCQA and HEDIS auditing and HEDIS measuring. And then lastly, there's the issue I think most of us are aware of that's called the triple aim. The triple aim aims to lower costs, improve health, and achieve better patient experiences as they go through the healthcare system. So those are those 2 pieces that I put a lot of my own attention on. Never forget the 5 Ps, understand the degrees of intersection of those Venn diagrams. Sometimes they may not intersect at all, but just be aware that the 5 areas are there. And then for CalAIM, NCQA, HEDIS, we've all heard those terms, I'm sure, over several years. We probably have varying degrees of understanding of them. We probably have varying degrees of understanding the significance of them and how they interact with all those 5 Venn diagrams. But if you don't understand how they work, that would be one piece of advice I would throw out to the group. This is not a paid political announcement for NCQA or HEDIS, but I think those 2 tools, when applied to the CalAIM initiative, can do tremendous things, but it involves getting people familiar with the tools and be willing to use them systematically. Before I stop talking and let Kate get back to the questions, I just want to give one other area of interest that I hope could be addressed at some point in future months or years. But I thought I'd like to bring it out at this forum today. I've been a doctor for 48 years. Seen a lot of water, go under the bridge, over the dam during those times. And currently, I do medical record reviews on over 100 cases a week. These are usually complaints or grievances that originate from our company, Anthem's system, and or other pieces of the healthcare system. And as I read through those cases every week, it just drives home to me the sad fact of how weakened our system has become. We certainly haven't been helped by the pandemic, but that really isn't too much within our control. But one of the things I'd like to bring out is there's been such a depersonalization of care. It's really affecting everything we do. And the complexity of our system, or our microsystems, really requires, I know this is an old-fashioned term, but navigators. And one of the things I've been trying to propose with my own colleagues at Anthem is this notion that's been tried and proven by other managed care organizations, but taking your highest risk members and assigning them to a navigator. So you may have one navigator with a cohort of 50 members, and that navigator is intended to be the linchpin, connecting the patient who's very high risk, may be very confused, may not understand what a PCP is or how they can work a computer or a phone. All those people need our attention. And I just hope we can get into discussing all the inputs that have put us where we are today, if not discussing them today at some future form. So let me stop and throw this back over to Kate for other questions.
Thank you, Dennis. I'm so glad you brought up the issue of quality, and I see that there's a question about care coordination in the chat. I'm going to actually jump to and this around this issue of navigation and care coordination. The policy is being written now. It's in draft form to incorporate the community health workers and sort of associated peer specialists as Medi-Cal providers. It's supposed to go live in July. Given provider shortages that includes covered providers under the non-specialty mental health services benefit, how are you integrating expanded provider classes into the non-specialty mental health benefit? And how can managed care organizations ease implementation barriers, such as with credentialing and paneling procedures? Maybe I'll go to Vanessa to ask you this question in terms of how SFHP, and I know your partnership with Beacon, is approaching this issue.
So as far as SFHP, we are definitely taking a look at what we have currently as our capabilities and capacity, and really working hard with Beacon to discuss quality as well as what are our needs and our gaps and barriers. So we routinely meet with Beacon Health Options, who provides much of our behavioral health services. And we've also opened the door to making sure that we increase these communications with Anthem in regards to bringing in the school district as well as county behavioral health into this conversation, because we have many CBOs that are providing these behavioral health services in the schools. So really having an idea of what is available in the landscape of San Francisco for our young people, and moving from there to the next steps of who else do we need to bring into this conversation, as well as how do we possibly navigate creative ways of bringing in more professionals into the conversation.
I think there's a lot of interest in this, using alternative providers, as it were. I know that's not the right phrase, but several months ago, I was having some conversations with a group of dentists up in Sacramento County. And we got onto this topic about immunization rates, why they're so lousy in certain parts of the state, and what could we do about it to improve it. And I threw out this idea to the dentist. I said, you guys inject anesthetics into little kids' mouths. Sometimes you put them under general anesthesia, give them local anesthesia. Why couldn't you do some of the things that family physicians, nurse practitioners, and pediatricians do, like give immunizations or check on your immunization status? They've put together a tool up there that is able to link, I believe, immunization status with members when the pediatric member shows up in the dentist's office. So this is all about how do we, as you all have mentioned already, but how do we leverage existing resources and convert them into performing a role that's non-traditional for them. And then the possible outcomes of something like this, I think would either you could see the good, the bad, and the ugly, but there would be some pediatricians probably who'd see this as a big competitive effort that's going to muscle in on their practice. Others may feel just the opposite. They say, this is me giving back a little more to my community and helping these immunization rates get better. So it's just a thought. I think there's lots of opportunities for getting into this. We at Anthem, in many cases, are just at the beginning. So I don't think it's fair for us to say we've got all the answers yet, or we've got all the solutions drawn up and ready to roll, but it's definitely part of our work list for this coming year and next.
Great.
Yeah. And sorry, just to add very quickly, I know we are also hiring internally a fleet of community health workers. I mean, we already do have community health workers, but also we are constantly hiring and also supporting the staffing build out of our providers who are also looking to hire for their own organizations. That's part of the Callium drive, but as I'm sure most of you know, it's really difficult to hire right now. I mean, there's so many complications to this. Like there's like in terms of providers and also community health workers becoming Medicaid providers. There's so many barriers to this. One is also just like logistics, like where are they? How can we get more on the ground, trained, licensed, ready to go? It's actually something that we're working through like internally as we speak. But yeah, in parallel to building out existing infrastructure, like Dr. McIntyre was mentioning, like we want to know where we can make the work that's already being done go further. So whether that's building out IT or building out bigger, broader community care coordination networks, I think that's one way to do it. And then also in parallel, in tandem to that, we're actually working with providers on the ground and also working internally to get more community health workers up and running. I think something that we would love to be more actively involved in, and we haven't figured out quite how to do this yet. We sort of started with these monthly webinars that we're doing for Callium, but we would love to do more of like shared lessons or training the trainer, especially for roles that are brand new, like we're talking about for community health workers who maybe would just now be getting the license to be a Medicaid provider. What does that look like? How can we help them get there, and how can we help share insights from what we already know? And then also for organizations, like I mentioned, like community-based organizations that are also getting licensed to become Medicaid providers, like what are best practices? How do we also help them get there? So that's something that we're looking to do. I'm sure once we figure it out, SFHP would be on board to do it with us. Currently it looks like monthly webinars, but we want to do a little bit more hands-on than that. So that's where we're going.
Thank
Just
you.
want to throw in one quick comment if I could. Just one real quickie.
We'll do one more minute on this one, and then I'm going to shift us over to one of the newer non-specialty mental health benefits.
Okay, go ahead, Kate. I'll hold my fire.
Well, it's okay, Dennis. You can finish your thought.
Well, just saying, as we might get frustrated from time to time, as we try to tackle these really big issues and big projects, just remember that it takes 8 to 10 years in the medical community to get general acceptance of what people call a medical breakthrough. A big discovery is made. It's put out for consumption. Thing that happened years ago, not too long ago, but a couple of decades ago, was the treatment of peptic ulcer disease. It was revolutionized, and people still didn't use it, for a good 8 to 10 years. Now it's become history. So it's just something to console you as you go through some of these really tough days. You're not alone.
Thank you.
Thank you.
Great. So I'm going to shift us over, and I would love to hear both from SFHP and then also one of the Anthem reps on this preventative and health promotion, behavioral health promotion benefits available through the non-specialty mental health services benefit. So as many of us know, over the past 2 years, California DHCS has taken major steps towards increasing access to behavioral health prevention and promotion for children. Under the non-specialty mental health services benefit, they've fundamentally redefined medical necessity by allowing families to access billable mental health services in primary care settings and other non-specialty mental health providers without the requirement of a DSM mental health disorder. So under the expanded psychotherapy and family therapy services, providers can now use a package of Z codes that are indicative of environmental risks, such as caregiver mental health concerns, exposure to community violence, experience of discrimination based on race, gender, or another factor. Or also for children who show up with subclinical mental health symptoms, not meeting criteria for a mental health disorder, they can receive reimbursable services. The dyadic benefit is coming and is expected to expand on this by offering a behavioral health well child visit. That said, there's a lot of confusion around how to access these new benefits, whether the codes are live in managed care organizations, whether providers know about them. And we're wondering, what plans does your organization have to increase access to mental health services in this domain, knowing this affects millions of children and families who may have the opportunity to mitigate or completely prevent a mental health disorder from developing? What's been the uptake and utilization of these new benefits, and what have you learned from implementing benefits such as these?
So Kate, I want to give Vanessa the opportunity to go. I feel like we went first the last time, but I'm happy to go with Vanessa. I will let you kick off if you want.
Yeah, no problem, Alicia. Thank you.
Yeah.
So it's still a work in progress. So a lot of this information, we're building the plane while we're still in the air. In terms of sometimes the billing codes, a big thing for me as a prior mental health provider is the use of these Z codes, because it captures so much of the patient member's history that needs to be a part of the conversation, no matter if they're seeing a physical health provider, behavioral health provider. Those social determinants of health come into play a lot of the time, specifically with trauma and any unmet need for our members and our patients. So a big part of SFHP is also providing that education to our providers through our provider newsletter, and really promoting any type of practice, specifically best practices and strategies that will make sure that our members have their needs met, and also that their care is at the highest regard. There are so many new initiatives that are coming out, and we are trying to wait for guidance. A lot of times we're waiting on guidance from DHCS. And we're also trying to, put together some of our solutions too while we wait, and do our research as well and our due diligence to see what else is happening across the board in other states that have rolled out similar initiatives and changes. I hope that answers your question, but we're basically researching, consulting, and working closely with like Anthem and other sister plans throughout the state to see how they're implementing different behavioral health initiatives, and just trying to see what will best work for our community, because San Francisco is very unique and we want to make sure that we have everyone involved in the conversation. So really increasing our communication and collaboration and feedback from UCSF as well as other providers in the field. So if you do have a question and you want to know, hey, where are you at with this, please send an email over to us, because we're working on this as soon as everything's coming out and trying to increase our behavioral health programming as we speak right now. Alicia or Carissa, if you wanted to take it away too.
Yeah, I would just add to that. I mean, and Vanessa, to add to what you already said, like, I think that was a great overview. I think we are working very closely with our other managed care plans. I think the state has made it clear that kids' mental health is a priority. And, with everything that has gone on from, kids being home from COVID to, the fact that the state is really focusing on things like ACEs, the Student Behavioral Health Program. I know Vanessa and I work very closely on implementing some of these programs together, along with our other colleagues. We, as a managed care plan, we understand that access is limited for kids, and not all families are able to get access to those services, whether it be a transportation issue, whether it be the fact that maybe they just are not comfortable with their child accessing those services. So, we have as many of you know, the Student Behavioral Health Incentive Program that is rolling out, which we are working on across multiple counties with many of our school districts. I think the goal of the program was really to make sure that we are breaking down the barriers. And as an example, I can just say that, we were in the room with many of the school districts, many of our community-based organizations who serve children, First Five, things like that. And many of them were like, we've never been in the same room as the managed care plan, the county behavioral health department, the school districts, and the community-based organizations together. So I think that these programs are meant to address the fact that our kids do need these services, right? Especially after the last couple of years that we've had as a state, a country, a county, however you want to frame it. But, at Anthem, we're looking at not only, I think, there's many interventions around what can be done for our kids in the communities where they're being served. And I think that as health plans, we oftentimes, because of the lack of providers that are available for our children to have access to, we often think, maybe telehealth is a great option. I think some of our school districts have been like, yes, we want that as an option, but we don't want that as the only option, right? We want to make sure that there are those in-person interventions that are available to our kids. We want to make sure that our community-based organizations are available, that there's that peer-to-peer support for kids where they have an option to weigh in on what services they're getting, because, they know as children what works for them, even though sometimes I think as adults, we often think, we have the best solution for what's going to work for them. So as Vanessa mentioned, I think we're working very closely with our community-based organizations. We're working closely with our county behavioral health departments. We're working closely with the contracted providers that we work with who are seeing the children within our communities, and trying to expand access and make sure that there are no barriers, whether that be transportation, whether that be they need devices to access telehealth from kiosks that are available on site for schools. There are multiple ways that we can expand access, but I think that the state has done a pretty good job of wanting to provide us those resources so that we can work together to collaboratively make sure that these kids have expanded access. Because I think after, the last 2 years that we have experienced as, plans, as, community-based providers, as, physicians, we see that, there is a real need for these kids to receive those services.
Thank you. Thank you so much. I'm noticing, I know that we are at time for this portion of our panel, and there are so many unanswered questions that we haven't been able to get to in the chat, and I apologize for that. I knew we were going to have a lot of interest here. I'm thinking that what we can do is capture these and probably provide some responses in a kind of FAQ or Q&A format, in a written format on the way. Thank you, Anda, after the session is done. So I want to just thank you, Alicia and Vanessa and Dennis and Carissa, for joining us today. I will say in response to some of the questions I'm seeing that we at UCSF at ZSFG have found Anthem and San Francisco Health Plan to be really incredible partners in thinking with us, are committed to these issues and providing information, especially around whether codes are loaded and being reimbursed. And so I would just kind of reiterate that they've been really wonderful partners and that the invitation to reach out is very genuine. So thank you so much for joining us, and I will turn it back over to you, Anda.
I'm actually going to jump in here, Kate. Thank you for the fantastic facilitation, and Vanessa, Dennis, Carissa, and Alicia, thank you for all of your expertise. we want to continue working with you. So my name is Dana Long, and I'm co-director of our Center for Child and Community Health with Aranda. And we are now going to launch into what I'm very much looking forward to, which is a conversation with our school-based mental health professionals to talk about sort of what the barriers are and opportunities. We have representatives from across San Francisco and Oakland Unified School District. Today's panel is going to be moderated by the absolutely fantastic Sauntoy Trotter. Sauntoy is the clinical director of school-based health services for UCSF Benioff Children's Hospital, Oakland. And joining Sauntoy today on the panel, we have distinguished guests. We have Quarry Park, who's supervisor for Student and Family Services Division at San Francisco Unified School District. We have Barbara McClung, who is the Director of Behavioral Health at Oakland Unified School District. We have Lisa Carlisle, who's the Director of Children and Young Adult System of Care at Alameda County Behavioral Health. We have Anna Mejia, who is the School-Based Program Director at Lincoln Family Center. And we have Joyce Dorado, who is the director and co-founder of the UCSF Healthy Environments and Response to Trauma in Schools, also known as the HEARTS program. Thank you for being on this panel about school-based mental health, and I'm going to pass it over to you, Sauntoy.
Thank you so much, Dana. This is such a beautiful panel. I'm so thrilled to be here with just many of my heroes and mentors and just people who we've been kind of arm in arm, shoulder and shoulder in the work, and to meet some new people from across the Bay. So thank you so much just for all the work that you all already do for school-based health, and just also want to call out Ella Muir and Kimi Shakashida and Barbara Staggers and Lisa Warhos, all of the folks who have been doing this work around school-based behavioral health for so long. And we thought it would be helpful to really start with a sense of what's already happening. I think, currently there's a, almost this sudden shift of zoom and focus to, we need mental health in schools. And what we know is there's already mental health happening in schools, partnerships between districts and community providers, wonderful, amazing work that's happening. And so first question, if you can just share, and maybe I can ask Barb and Quarry first from the district level, what's happening? What do you want healthcare providers to know, but what's already happening? What are the things that you want to lift up in terms of school-based health in your district?
Want to go, Barb, or should I start?
Why don't you go ahead? Yeah.
Go ahead, Quarry.
My name is Quarry Pak. My pronouns are she and they. So representing my team at San Francisco Unified School District, we are a team. Joyce is part of our team too. And we have really focused our work on family needs and meeting them where they are with the most basic in terms of, referrals to services and food, because we are a connection and linkage to a lot of food programs. And so I'm just within the past 2-3 years coming out of that and welcoming all students back in person this past school year, and all of our subset of our students with various needs and priorities the previous school year, as well as supporting our staff through this time. But we do focus, and I was so glad to hear Skye in the beginning on health education, prevention, family-based work, comprehensive health education, access to services, which is so important right now, and coordination with our community providers, and ongoing services that are school-based for mental health with our city and county partners and our community partners. So just trying to wrap around services for our children and youth, that there's not enough out there, and there's a lot of crisis and improvement that we can do in coordination and transitional plans. I'll just leave it there before Barb picks up.
Okay, thank you so much. And also nice to meet you, Quarry. I think to build on what you said, some of the things that we're doing in OUSD, we're really building out what we call a multi-tiered system of support with all schools, and we're using that as a framework with which to align our resources and also to build our partnerships. So one example of this is that at every school in Oakland, we have a coordination of services team that is made up of all of the providers, both healthcare, mental health, after school programming, extended day, that kind of thing. We have teams at every school where we're trying to learn about and educate each other about our different contexts. And I guess like in listening, I'm really grateful to be here today because this whole world of non-specialty behavioral health is, strangely enough, it's very new to me, even though I've been in this role for almost 16 years, because it's been so siloed between healthcare and behavioral healthcare. And so I'm really excited to be in this conversation. But I can see just listening to all the different acronyms that I don't know. And I was like, oh my God, I get the acronyms out of what I'm about to say here, because it won't make any sense to anybody that's not in a school. I think our coordination of services team provides that opportunity for us to understand each other's language and context and services and referral pathways and that kind of thing. So that's one of the things that we're committed to in building our partnerships. And also we're really valuing and lifting up the notion of inclusion. And so thinking a lot about our students with disabilities and really trying to maximize the services that are available through general education so that whenever we can, we're preventing students from being moved into a more restrictive setting just in order to receive education, right? We're trying to create inclusive, differentiated instruction and differentiated kinds of services within our schools, including classroom-based services, leaning into social emotional learning and other ways that we can, and restorative practices as ways that we can build community, and we can also build empathy and understanding between students and among students and staff. And I think I think one of the things also that I'm pretty sure we're all focused on here because we're dedicated to health equity is that we're educating ourselves and each other about implicit bias, and we're taking active steps to eradicate anti-Black racism, other things like transphobia and sexism that are in our schools and that are embedded within our institutions. Those present some significant barriers to service that are often invisible. They just seem like the way things are. But we've really taken that on within our behavioral health unit in OUSD and across our schools, so that we're not just looking for individual solutions, like let's remove the symptoms in the student. We need to also remove the barriers and structures within our institutions. And that's something I think we're all partnering on really well.
I appreciate you lifting that up, Barb. And I know that Alex, when he presented, was, just really reminded us, like, our kids are great. Our kids are whole, they are well, right? It is like, what is the environment? What is the society that they're inheriting, right? And, what are the ways that we are addressing that institutional and historical oppression so we can build the capacity for wellness in our schools and in our community? And I know that there's some great, like, kind of trauma-based programs, and wanted to just pass to both Joyce, Dorado, and Anna, if you can speak a little bit about the work that you're doing to address trauma in schools and build capacity.
Anna, why don't you go first?
Sure, thank you. Well, I also was going to actually highlight costs, because when I thought about, when you said what's working well, I did want to, the first thing that came to mind was costs. So I do want to highlight Barb and her work that she has done. I know it's for the framework of what costs can look like and what it should look like. And it is really helpful for us to come to a table with other providers and other key people in the school to make a decision together around what can be best for a child. Also, what's going really well in our programs, we are at 16 different schools in OUSD, and our program model is to have a therapist and to also have an intervention specialist in our elementary schools, which means that we have people who are usually from the community that are providing that in the moment support that Barb was just talking about, that in the moment support at recess, in the cafeteria, in the hallways, in the classroom, to provide more of a kind of a team-based model, right? Where the kid knows that they have a Lincoln team behind them to help them be successful for that school. I would also highlight our great partnerships that we have with admin right now in our OUSD schools. I've been around for 11 years, so I feel like we have some strong relationships, and it's really nice to be able to meet with admin and to have a reflective space where we can discuss, what do you feel that you need? How can Lincoln support you in this year? And some amazing work I do want to highlight. There was 2 schools in East Oakland who shared, you know, we're going to have an uptick in referrals. There's lots of kids that need services, which I'm sure we've all heard about. And our services do focus on tier 3 students. However, these 2 schools put funds aside for us to support tier 2 students. So the kids who just need a little bit extra support to prevent them from being tier 3. And so what we did is, with the help of Francine Ostrom, we were able to provide expressive arts groups for tier 2 students in both schools throughout the whole school year. So these schools were able to get expressive arts every single month. And we would rotate the kids with the help of the cost teams, where the cost teams were able to identify the kids for us and just to have a bigger impact. So in a nutshell, I would say that our partnerships is what's going really well at our schools.
Thank you, Anna. And just clarifies folks who aren't in the school world, right? Tier 1 is really universal services that for all students. And then tier 2, more specialized kind of maybe group or skill building services. And tier 3, more intensive mental health services. And I want to just pass it to you, Joyce, to share about some of the work that's happening in schools. And then the next question for folks to begin to think about is, how can healthcare providers better partner with behavioral health with schools, including behavioral health providers in schools, to meet the needs of our community at this time? Go ahead, Joyce.
Thanks, Sauntoy. It's really great to see so many of my friends and colleagues here. Barb, it's been too long. And so great to see you too, Lisa and Kari. So I have the great good fortune of having started and run an organization called Healthy Environments in Response to Trauma in Schools. And we partner, we have long, deep, sustained partnership with SFUSD. We had multi-year partnership with OUSD back in the day. And what we do is we partner. I'm a clinical psychologist by training, so I'm a mental health provider. But we partner with schools and school districts, educators, to try to help bring a trauma-informed, healing-centered lens to their expertise as educators, so that they can do their work well as educators while staying well in the process. And we do that through professional development training, consultation, and when there are resources, also on-site tier 2 and tier 3 services for trauma-impacted kids. And so, I mean, I can only speak to just what wonderful partners both San Francisco Unified School District and Oakland Unified School District have been in this work. We got to slot in with all of the wonderful tier 1 and tier 2 work that they've already been doing around positive behavior interventions and supports and restorative practices, restorative justice, and just bringing that lens of understanding how trauma can affect any of us as human beings, not just kids, but us also as adults, how it can affect our relationships and our work and our health. And then really what anybody can do, regardless of who you are on a school, in a school building, to help contribute towards healing as opposed to harm. And also to make sure that our educators, the adults in the school, caregivers are also well. And so that's in a nutshell what we do. And racial justice is very much at the center of everything that we do. And again, it was just so great to partner with OUSD because you were already doing that work through restorative justice and all of the rest of the work that you've been doing. And same with SFUSD. We entered back in 2008 when the 5-year strategic plan got into place, where they were really trying to specifically address this school to prison pipeline and dismantle that. And they understood that that wasn't just about having stronger math curricula, it was about actually addressing the sociopolitical underpinnings of the opportunity gap. So I think the main thing I want to say here too is that, like, while I do think specialty mental health care services or tier 3 services are important, we all know that sending kids to therapy is often not the solution, and that if we're not if all of the adults in the building are not also contributing towards healing through their own behavior, through their own interactions, through their own practices, then we're kind of I sort of feel like we're spitting in the wind, because kids spend most of their time not in therapy with us, right? So that's again where OUSD and SFUSD have been great partners in that, because they truly understand the importance of tier 1 and tier 2 supports.
I just appreciate so much what you're saying. You know, schools can be a place of harm, or they can be a place of healing, and just all of the capacity building. So it's not only individual therapy or groups for the young people, but also that capacity healing that's happening for the adults and for the families and parents and caregivers that are part of a school community.
And Sauntoy, you're being very humble here, but of course you've been doing this work for so long, and you're incredible at this work too. So Sauntoy has been a partner here in that.
Thank you, Joyce. I'm honored to be a part of this community. And I'm gonna bring it to Lisa Carlisle, who I feel like you have such a beautiful perspective and kind of witnessing and holding school-based behavioral health providers for so long at many different levels in the county, and, you know, throughout the whole county. And so you can share, like, kind of what do you see in terms of, like, what is the best way? Because I think, you know, inside the UCSF system, part of the question are pediatricians and primary care and specialty, you know, medical health providers are looking at, it's like, how do we better partner with schools? How do we, you know, there's so many young people who need mental health services, and there's wait lists, and it's hard to hire, there's workforce. So what's the best way to partner with schools in order for our shared goal, right, of kind of optimal health and well-being for young people?
Good afternoon, everyone. And Sauntoy, that is a meaty question, and I will try to respond to it in pieces. But I want to start off with saying I don't believe that there is a one way. I believe that there are multiple ways that may work for different partnerships. So I want to open with that. But I think generally speaking, what's important is what we're doing now in providing mental health education, not education on mental health, but mental health education to our school district partners. It is very nebulous, right? It's this thing that floats around, and, you know, MTSS or RTI or PBIS, it's this thing that floats around. And what I have found helpful over the years is to really educate our school systems on, here's what mental health is, here's what it isn't, just from a very basic perspective. There's often a sense that mental health is the absence or presence of a diagnosis, when that's not the case, right? And we often see mental health at the extreme with students in psychosis that are needing hospitalization. But there's a whole continuum in between. So starting with that, with really just having conversations with our district partners, here's what mental health is, here's what the continuum looks like. And then from there, backing into looking at the continuum, here are the different types of services that are on the continuum. And it's not all just the 50-minute clinical hour. That's what we're used to, right? That's what everyone's familiar with. But there is family work, there is mental health consultation, there is prevention work, there's care coordination, there's case management. So there are a lot of things that are included in what mental health services look like at schools. What has worked over the years, you know, there's no easy way to do it. We as a health plan, you know, back when I was delivering services, I feel like many moons ago, and when I started administering services, there was no easy way to do it other than for me to be on campus, other than me to meet with the principals, to meet with the school district, just try to sit in on cost meetings and doing trainings and consultations with staff, explaining to principals that don't understand how they are expected to educate all the students and youth. And my staff can only support the youth that have Medi-Cal because that's our insurance plan, right? So there's a lot of foundational work that is needed to get to those easy flowing cost teams, to get to that information sharing. Also, what has worked is having either an ally or group of allies in the school district that can go to bat for mental health. We've experienced very well-meaning educators, and I can say that because I am an educator, right? I was trained in education. So when I say they, I really mean me, right? I learned, I go back and look at my transcript all the time and try to figure out where it was that they told me that my lesson plans weren't enough, and they didn't. And so we have to, I've learned that as mental health providers coming on a school campus, we have to humble ourselves and recognize that you're inviting two subject matter experts to work with the same group of you. You're asking the educational subject matter experts and then the mental health subject matter experts, which sometimes inadvertently step on each other's toes. And, you know, educators, we have a task of when a youth is underperforming in something, you put in a number of interventions. By 3 weeks, they have mastered multiplication. You put in the, you know, you do the table, you do the drills, and now they can pass the test. Mental health doesn't work that way. Mental health can be much more long-term. It can take much longer to ameliorate symptoms or decrease symptomology or decrease acuity. And that's really the meat and potatoes, so to speak, of the work, is continuing to work with our school district partners and say, hey, Lisa used to scream and throw chairs. Now she's just screaming and she's not throwing chairs. Lisa's still disruptive in class, but the level of disruption has decreased. So like that is the work. The work is in the nuances of what's actually being seen on site. It's drawing in the administrators. It's trying to engage families. It's showing up at staff meetings. If you can get 15 minutes, and it's really hard, but to get 15 minutes and do a quick primer on behavior modification and how your interventions can turn the classroom around or upside down, depending on which intervention you choose. But that's the service end. In terms of the administrative piece, what we're moving into is we are now looking at schools as much more than educational systems. And we as mental health providers and healthcare plans, we really have to help them to prepare structurally for managing healthcare at the school site. It may be cost teams, it's community schools managers. Barbara, using your district because that's those are all the acronyms I know for your district that I think folks are familiar with. But there's also, okay, well, who's going to be the subject matter expert at the school site for navigating all the healthcare systems? Because as we're moving forward with really trying to integrate this work, we want to make sure that the schools are prepared to, and we talked about it earlier, we talked about navigators for the families and students. We also need navigators for the school administrators to help to navigate all the health plan systems because we're very complex. Specialty mental health is not the same as what you're seeing with the Alliance or Anthem Blue Cross. They're trying to bridge it together, but we all have different rules. You heard about HEDIS measures earlier. We don't have HEDIS measures in behavioral health. We have RBA, results-based accountability, right? So there are different things that you're going to be experiencing from the different healthcare systems that are going to take some time to understand and navigate. And so I see the landscape moving forward is really helping to prepare all of our systems to speak each other's languages, which is very different than getting together to decide what services a youth may need. That is important, but there's also a cross-educational piece that we're going to have to start doing with each other so that we really understand the intricacies of our different systems. I'm going to pause because I could talk about this forever, but I also don't need to take up all the space. So, Sauntoy, I'm going to turn it back to you.
I appreciate the space that you're taking. And I think I want to build on what you're saying, Lisa, around, you know, what we've learned is that there's educators, mental health providers, like how do they talk to each other? I need to lift up that both San Francisco Unified School District and Oakland Unified School District are leaders in community schools movement and school-based health centers, right? That there's, you know, such pockets of deep expertise, and also Oakland in terms of the work leadership around restorative justice. And it may be happening in San Francisco that I don't know. But so just like there's so much here. And I think one of the questions is, for healthcare providers who, I appreciate, Lisa, you're speaking about how do schools, what's the infrastructure needed inside schools to help be that bridge to healthcare? And then maybe for Barb and Quarry, like, what do you need from healthcare providers, maybe not those who are in school-based health centers, but the rest of our healthcare providers to support that communication, right? Because like cost, right, that collaboration, we see how effective cost and the collaboration and coordination and partnership is particularly in meeting the needs of young people while they were off school sites, meeting mental health needs, healthcare needs, food needs, technology needs. But for those who aren't already embedded in schools, how can they best communicate and have that flow of communication to collaborate with schools?
Thanks for the question, Sauntoy. I just have to echo that there's a social worker and or nurse or community health outreach worker at every SWC school. And I want to thank Amy Woodall and Anna Tuko for inviting me here, because I do share, like, this is the contact for Washington High School. This is the contact for Thurgood Marshall, and call them directly. And what would be most helpful and effective, what is most helpful and effective is those lines of communication that are open with the family to say, let's make this phone call with the family now, or email, the counselor to let them know what's going on, like why these absences are happening or what accommodations would need to be happening through general ed, as Barb mentioned. We really need to get more information and share more information on an ongoing fashion to be able to support educators and families and students to have a web of support in terms of that's very responsive, and kind of there's a spiral of checking in and a regular maintenance of like, okay, well, that improvement is happening as Lisa spoke with, or it's not working, and like we need to change it up and not have like a 4-year-old IEP that's still not connected to the students. Especially during the pandemic, a lot of things were delayed or newly emerging, and so we're trying to catch up on all of our services and adjusting. And so the communication is so key, and especially in crisis situations. And so a lot of times we hear from the parent one thing, we hear from the provider another, and then the student says another thing. And so we have to paint the full picture, and the teacher and the counselors and the nurses at the school site together can paint that full picture so that we can give students what they need and families as well, especially for those all ages, but especially for the younger students. So we just have open lines of communication. So encourage that to continue, because it's evolving situation every day.
Yeah, I would build on that. I think, just as we're here, I'm looking at like the medical providers call the kids patients, and then the managed care plans call them members, and then we call them students. And each of those has there's a particular culture that's embedded, that name resides in, that label resides in. And we need to start to understand what those cultures are, because I think I've been to a doctor myself. I've had my own kids. I know something experientially what the medical provider side is, but managed care plan. Now that's a very obtuse to me. I can't see into it's opaque. I don't know what exactly is in there, right? And I know that that's how people experience schools, especially when, people may know about the educational services in schools, maybe not also, but when you start talking about mental health and you think about students, I know that it's very difficult to figure out, how do I get in touch with somebody at a school that would be doing something about mental health? Who's that person? Where's that phone number? What's that position? Is there somebody that does that? Is it on the website somewhere? And it's not. And those positions change all the time. And so I know schools seem very opaque in terms of from an outside perspective. And then we have a culture of kind of keeping people out too. So, and that's not an intention, but there is a way that, each school has its own community, its own system, right? And there's a lot of demands on schools. We're very under-resourced. And so there's a way that it can become very insular, right? And so I just want to thank Melanie. I want to thank Sauntoy. I want to thank Dana. I want to thank everybody here for this conversation. Like, we're finally having it. It's fantastic. We need more of this. We need to understand what a member is. We need to understand what a student is. We need to understand what a patient is, so that we can put our referral into the context of that particular culture. That's a culture, and we need to learn each other's cultures.
I really just appreciate you speaking, Barb, to how specific each school site is, each community, that it is its own little town, you know, and you gotta like find out whoever, you know, that part of kind of collaborating with the school is taking the time, as Skye said earlier, right, to build those relationships. Like, that is the foundation. And then what you're saying, Quarry, is like, there is someone at the school, right? Call me. If you don't know who to call, find someone at the district, call the Barb McClung, call the Quarry Park. Who at at this school do I go to for this, right? That there is a way. It just kind of sometimes takes some navigation and exploration. And you spoke to just amazing creative expressive art therapy that's happening. And I think one of the questions that we're all holding is like, how do we increase access to mental health care? And that can look different ways. I think the opportunity with CalAIM, with the new insurance, like we're, in the last panel, it was like non-traditional healers or non-traditional ways of providers, but I would say it's traditional healing, and that the insurance is catching up to, right? It maybe look non-traditional in the insurance world or maybe the healthcare provider world, but it is, we're kind of getting back to more community-based traditional ways of healing, and having that be more universally available. And so could you share anything about, the work that you're doing at Lincoln to increase support access to behavioral health care?
Well, I think I'm going to reference Lisa, because what she shared is so true. Oftentimes, schools are very busy and there's a lot on teachers and admin's plate. So it's really important for us to go in there knowing that we are guests at their schools and finding the wiggle time to get into their PDs, to talk about our services, to make ourselves accessible for the teachers, and also collaborating with OUSD's mental health managers, which Barbara has supervised, and they're fantastic. I have all their numbers on speed dial on my phone. And if I'm noticing that a school, we're not getting a lot of referrals, they are the first people that I contact. Hey, there's not lots of referrals at this school. What do you think we should do? How can we make a plan together to come in? So it's not just Lincoln's perspective, but that we're also always collaborating with OUSD. Usually getting referrals is not a problem in a lot of our OUSD schools, but sometimes that happens. So it's more about the psychoeducation of how to refer, and also doing the early intervention and helping teachers identify symptoms or things that could potentially mean that a child needs a referral, or they might just need a check-in. So it's a lot about providing kind of our schools just the information around who we are, how to access our services, and also maybe sometimes a teacher might just need support and figuring out what are 3 coping skills that she can utilize in the classroom to help everyone be able to regulate, right? Because I think someone said we could all benefit from mental health, right? How to help a teacher develop a break zone in their classroom. So when a kid is upset, it's okay. They can go to the break zone, or the chill zone that a lot of kids like to call. And we do that. We support teachers in creating those kind of tier 1 supports, interventions. And we go into the classroom and provide workshops where we help take away the stigma of saying we all have big feelings, we all have big emotions, and we deal with them differently. Let us teach you some tools of how we can do that. So
yeah, such an important message, especially now. It's,
exactly.
More, it couldn't be needed now more than ever. I just want to give people a chance, just one last comment or things that you want this UCSF healthcare system to know or the community to know. Thank you so much, each of you, again, for all that you do for so long to support the health and well-being of children, families, and communities. And I'm gonna, Joyce, give you the last word and then kind of go around and if people are able to stay on.
It's great to hear all of the wonderful work y'all are doing. I guess I would say, in terms of how best to work with schools, what we have found to be the most helpful thing is to, yes, find it SFUSD, there's a school social worker at every school to try to get a hold of that person, or the school nurse, the community's, I forgot already what the OUSD is, it community services manager?
Community schools manager.
Community schools manager at OUSD. It just to know that there's a person at the school, so you know who to ask for when you call the front office if you're calling this school. And also, I would say, and maybe this isn't the right place to say this, but we might say it too. But when we, as mental health providers, are able to work with the child's teachers and or at least one important adult to that child at the school as part of the therapy, if we are providing therapy, that's pure gold. And sometimes health plans don't pay for that. But if you want to be trying to think about how do we actually help heal kids, is how we do that is we talk to their caregivers and we heal the environment around them so that those environments are not inadvertently harmful. To me, that's actually where the biggest chips for your cookie are, if you were, in terms of that work.
Thank you. It's such an important point, Joyce, in terms of that caregiver, including the teacher as a caregiver-child relationship and healing that happens inside of there. Anyone else? Anything else you'd like to share? We were about to close, but if there's something burning that you'd like to offer, we'd love to hear it.
I would just love to lift up the relationship that we have with Alameda County Behavioral Health Care and propose that as a model for how we might bring more non-specialty mental health care into our schools. So I think, the contracts, the medical contracts with community providers, they come into our schools. It would be amazing if some of those community providers could get contracts for non-specialty mental health so that we'd have the whole continuum right there in the school site. This is because we can build on what's already working instead of wasting a lot of time trying to think up something new. I mean, we do have a lot of amazing innovation, and I'm not talking against that, but we have some things that are working. It would be awesome if we could build on that to reach more students and build our collaboration together, which often happens through funding, right? So thinking about ways to braid funding.
Thank you.
We'll leave it there. Thank you so much. Passing it back to you, Dana and Anda.
Sauntoy, I appreciate your brilliance in facilitating that really robust conversation. And Anna, Barb, Lisa, Joyce, this conversation gave us so much to think about. And I loved the comment that was made about how this kind of conversation hasn't happened before and how do we continue it? And that's exactly what the HEAT series is all about. Being that we want to model practices of being healing and trauma informed, we are going to give our minds a 10-minute break. I actually am going to have everybody come back at 2:40, so it's 7 minutes. And when you come back, we're going to launch into a panel with health system leaders and really talk to the health system leaders around how we are making change. I also want to say that it's brilliant people like us who are going to make the change in the world that we need so badly right now. And so I'm filled with inspiration. All right, everyone, please stretch, take a bathroom break, get something to drink, and we'll see you back at 2:40.
Thanks, everybody.
Little more, just
Hello, everyone. Welcome back. I hope everyone had a chance to stretch. And we're going to kick off our afternoon sessions. So next, we're going to have a Deconstructing the Conversation panel, a chat with our local UCSF and hospital system leaders. So this chat is going to be facilitated by Melanie Moore. And Melanie is a friend, and she is also the CEO of Oakland Thrives. Melanie is going to be joined by our UCSF and hospital system leaders, including Bryan King. Bryan King is the Vice President of Child Behavioral Health Services at UCSF Benioff Children's Hospitals and the Vice Chair for Child and Adolescent Psychiatry at UCSF. Next, there'll be Jennifer Miller, and Jennifer is our Service Line Director for Behavioral Health at UCSF Benioff Children's Hospitals. After Jennifer, you will hear from Raphael Hirsch, and Raphael is our Physician-in-Chief at UCSF Benioff Children's Hospitals and the Chair of our Department of Pediatrics. And we also will be joined by Matthew Cook, and Matt is the President of UCSF Benioff Children's Hospitals and the Senior Vice President for Children's Services at UCSF Health. So Melanie, I'm going to pass it off to you to lead our panel.
Thank you so much, Dana, and welcome esteemed panelists, and thanks to everybody who's been on this call so far and participated in the other 2 sessions of this HEAT series. I have learned so much over the course of the last 3 sessions, and even though I'm not a hospital insider, a healthcare system insider, I feel like I have developed a deeper appreciation for how systems work. And as somebody who runs a collective impact organization, Oakland Thrives, it is so important that those of us who are trying to convene systems leaders have a deeper understanding of the systems that people like you all work in every day and lead, because only when we really understand a little bit deeper in the weeds can we think about strategic ways that we can really align and collaborate. So I'm so grateful for this space, and I'm grateful to UCSF Benioff Children's Hospitals for creating this opportunity for us all to come together. So with that, we have a short time for this panel, and so forgive me for sort of keeping us moving and making sure that all of us get our voices in the room, but really want to make sure that that we're keeping on time and on task, because we're going to have some great breakout rooms following this panel. So let's take a big step back and really thinking about not just today's conversation, but all 3 of the HEAT series conversations. You know, as health systems leaders, what have we learned, and what does it mean for the UCSF Benioff healthcare systems focused on children's health and well-being? And Matt, if you don't mind, I'll pick on you to start. You know, as you sit back and reflect, we've talked about everything from Z codes to managed care plans to what happens inside a classroom. How are you as a health systems leader taking this in and thinking about the next step priorities? Where do we go from here?
Well, I think if we've learned nothing, Melanie, I think we've learned that this is an incredibly complicated set of issues with no easy answer. You know, it's sort of, I think it's a little dizzying almost what we've heard over these last 3 sessions. But what we've also heard is a few things that work really well. And, you know, certainly going out into the communities and into the schools, there's been some clear progress that's been made. I think one of the challenges for me is once a child is with us, we're too late. We've missed the boat there. And so for me, it's really about how do we partner more effectively and more broadly with our communities, the schools, with the primary care physicians, et cetera, to do something fundamentally different than what we're doing today, because that's really where we're going to make progress. Progress means we don't see them at the Benioff Children's Hospitals, in my mind. And so I really think we need to step back and say, what is possible and where do these funding streams come from to help us to organize all of our resources in a different way. And I'm kind of eager to hear what both Bryan and Jennifer can add to that.
Go for it, Bryan and Jennifer.
Okay, all right. So Jennifer, you or me? Okay.
I'm fine with either one of us going first. It's okay.
Okay, well, I'll jump in just because Matt has teed up a similar observation that's sort of overwhelming as we look over the series in total, that from the very first session, people were speaking to the unbelievable complexity of the system, which Dr. McIntyre, said that the word system is generous again today. That and when we were hearing about the innovative strategies to address some of the complexity, there were a number of examples of navigation supports, and that has come up again today. So one of the overwhelming impressions is just how diverse and varied our activities are, and to underscore that that UCSF Health is just a piece in this amazing, immense ecosystem, and what we need to do going forward is to really think about how we integrate and serve the ecosystem as a whole, as opposed to assuming that somehow we're going to be able to take care of all of the needs of the kids that cross our paths. I was taken by another one of Dr. McIntyre's comments today about the 8 to 10 year lag time between an innovation moving forward and being adopted, and sort of thinking about how that could be. And I think it brings up one of the other issues for me about our system, which is that in an environment that is so spectacularly under-resourced, people adopt survival strategies that become really critical to getting their work done. And all of these workarounds become very challenging to step out of in the absence of trust that the supports are going to be there for things not to come crashing down. It's very different in our system than what you might see. And I was thinking, about how long it took for the little winglets to be added to all of the airplanes, when people discovered that made things dramatically more efficient, and that you saved fuel and you reduced pollution, and on and on and on. It felt to me like all the airplanes had those winglets added overnight. And that's not us, precisely, for what Dr. McIntyre called out, that we were entrenched, I think, because we've been so under-resourced for so long. What's clearly happened, and it's evident in the series that we've all been taking in, is that the mental health needs of our population have reached a place where they just can't be ignored. And so we're seeing unprecedented investments from the state in mental health. And yet the other point that I think, and I'll close with this for now, that comes through so loud and clear, is that for us to fully take advantage of this investment, we need to all be working together much more effectively. We need to break down the silos that exist even within UCSF Health, but more importantly, the silos that exist across our system. I think that if we suddenly had some big bolus of funding that came our way, quite honestly, it wouldn't be clear what we would do with that. We don't have a workforce that's sitting around, looking for something to do. And the big bolus wouldn't necessarily give us access to a workforce that exists somewhere. We've heard how hard it is to leverage people. So as these resources come available, I'm hoping that we find a way to all get together and figure out how we take full advantage of this unprecedented opportunity.
And to that, I just to add to that, I think part of what is going to make a difference for us going forward is that we look at what has worked, and not just recently, but over the long history of how we've, as a humanity progressed forward. What are the things that makes us well? And we can get very stuck in silos on what that answer can be. And part of our collaboration going forward, and a point that Sauntoy made earlier, is that what we may now see as new, non-traditional, in fact, have been very successful ways to bring people to a point of wellness, and that we've let certain things get in the way of us understanding the merit behind that. And so culturally, for us to shift away from a very diagnostic specific culture into a community-oriented, village-driven culture where we are going to look to prevention to keep our kids and our families and our youth from getting so sick that we're stuck in this reaction mode all the time, and we'll never catch up. We would never be enough. And it's really important for us to begin to shift our thinking around that way of attending to what the needs are, and to really see where the needs begin, not where they've now ended up. And part of the challenge for us going forward is going to be to balance against, to Bryan's point, there is this desperate need now that has come to the surface for so long, having been ignored. So we can't just say that we're not going to pay attention to that. We will need to develop services in response, and be working just as hard to develop that prevention and the culture shift that's going to drive our ability to actually create a society that is focused on wellness in totality, not just in little pockets or very specific coded ways.
Bryan, you raised the issue of workforce, and Jennifer, you're talking about really rewiring and rethinking the way we approach these issues. Question for you, Raphael. How can academic departments actually think about training future pediatricians differently, given what we've heard in this series? Do we need to actually be thinking about a change in the way that we are approaching training our providers? You're on mute.
Just realized that. Thank you. First of all, I want to just thank the organizers of this HEAT series of sessions, Anda Kuo for really coming up with the idea, and all the people who helped her, Dana Long and many other people. It's been a phenomenal program, and I've learned a whole lot of things about it, including one that I think Matt said so well, which is, yes, these are healthcare issues, but they're much, much bigger than that. And as healthcare providers, we're only one part of the solution. We can't be the whole solution. It's going to require partnership with, as we learned, schools, community, government. As it relates to pediatricians and education, one of the things that we are increasingly understanding in medicine, there's really a revolution going on in how we think about health. And we are moving away from a world where, as physicians, we prescribe pills to treat illness and to improve health, chemicals, towards recognizing that what we need to be is more and more prescribing behavioral interventions, encouraging good, healthy behavior in our patients to improve their health. And the reality is that as pediatricians, we are poorly trained to do that. I have data I've seen that half of children being seen by primary care pediatricians in the community, half of them have behavioral and mental health reasons that they're coming to see their pediatrician. And the American Board of Pediatrics, which is the accrediting entity that accredits pediatricians and is responsible for overseeing the curriculum of pediatric residency programs across the country, has recognized that the curriculum is inadequate to the crisis that exists in our world today, in our society. And there are major efforts going on to try to put a greater emphasis on behavioral health issues in the pediatric residency training programs. And we're going to be seeing, I'm sure, more of that as time goes on. But those are, I think, just some of the things that we need to be thinking about to address what really has become a crisis for our society.
We've talked a lot about systems level approaches. We've talked CalAIM, big, statewide systems level of reform package. And we've also seen, even on the previous panel in the chat, folks saying, if you need to contact someone at OUSD, here's the name, here's the link. And so how do we avoid putting Band-Aids on what really need to be systems level solutions? We can, in the very short term, build better relationships and connections with each other. But for all of you, how can we strategically think about this dramatically increased demand for mental and behavioral health support across the board, from schools into tertiary care, and think about a more integrated and sustained approach that is systems level, as opposed to, hey, I happen to know Dana, so I know who to call.
I'll jump in. It's helpful to know Dana. We should all be calling Dana.
That is actually true, Dana. Just put your email in the chat right there. Just go for it.
I'd come back to what's been said by others here in this discussion as well, that that this is not a health system issue. This is an all of our issue that we're going to have to work together to solve. And each of us will benefit from having a fuller appreciation of what the important part that we should be playing in the larger system is. So I'm looking forward to the opportunity to connect on an ongoing basis with our community to think about, what does Barb McClung need from the child psychiatrists that we've managed to assemble at UCSF Health, or from the experts in particular subject area, or what have you. How can we provide the greatest benefit to the community? What do the payers need from our particular piece? And what does our health system need? If we think about UCSF as a tertiary quaternary health system, there would be an expectation that part of what we would need to do is to look after the deep end of the pool, if you will, and make sure that that there's coverage. But again, not necessarily exclusively. So how do we even take care of those needs in partnership? Stuff.
I agree with what Bryan is saying, is that we have a very specific role to play. And part of what will be important is that we play it alongside others on a team together. So the siloing would have to stop in order for this actually to be successful long term, so that we can make movement. And that's how at large change will occur. And we get into competition with one another in ways that are really unproductive and unhelpful. And that's another piece to this, that if we can do away with that and really understand that we are in fact all allies in this same journey, trying to get to the same place, that we can play our roles better. And I'm not required any longer to be the jack of all trades, trying to outdo everyone else to get to the finish line, when in reality, if I'm working in partnership with everyone, then it's actually going to happen, because we really do all want the same thing. And I don't think that we came to the table with a different intention.
No, I think it's an what Jennifer said in her last comments, made me think of something. And, fundamentally, when we talk about wellness, our health system wasn't designed from the ground up to promote wellness. It was designed to take care of sick people. And what we're trying to do is fundamentally shift that around in a particular area of health. And to Jennifer's point, there are resources out there. They're not sufficient, but we also don't want to recreate the wheel every time. So we need to figure out a way to coordinate amongst all these different resources, so we're not reinventing the wheel, on a daily basis, and then just calling or emailing Dana Long to, swoop in and help everybody. I do think, in a previous conversation, Melanie, that Oakland Thrive sponsored, I said we may need to look to other models. I mentioned Cradle Cincinnati, which was designed to reduce the infant mortality issue in that part of Ohio, and really had a community health worker focus in terms of coordinating resources. I think we're going to have to look at other, innovative models and borrow from some ideas and do some experimentation and see how that works, because we really don't have the luxury of recreating the wheel. We don't have the luxury of being in silos anymore, and not any single group can spend our way to fix this problem.
Hear, hear. I want to close quickly because we do need to move on to our breakout rooms, but I want to give an opportunity, Bryan and Jennifer, I know you have thought about some concrete next steps and takeaways, and may have a slide or two to show. But as a lead into that, I want to pick up on what Bryan said earlier about this big bolus of cash, which is out there somewhere that the state has offered up. And of course, there's philanthropy, and there's our other local systems, including our school districts and the funding coming down from the federal government for COVID relief, et cetera, which will continue to go on for a few years and can be allocated around behavioral health. So as we think about all of this funding coming down, how can we think about funding innovations? So Jennifer, I know you've thought a little bit about that. As you answer, maybe also transition into closing us out on this panel with some thoughts about where you all are headed in terms of concrete takeaways and next steps.
I'll jump in again. So I'm not sure that we need to queue up slides at this point. I think one image that comes to mind frequently for me in the context of the current environment is relates to the beginning line of the fisherman's poem that John F. Kennedy had on his desk that said, in effect, "The sea is so vast and my boat is so small." And the image that we're in, that indeed the sea of need is beyond measure, or feels that way, and our boat feels like an inner tube. And out in the middle of that sea, we literally could go in any direction and make a difference. There's no question that we could do something positive, but that's not strategic. And so one of the things that we hope comes of this that we can take forward would be for us literally to institutionalize, if you will, an advisory group, at least for our mental health service line, and put out the call now for anyone here assembled, community, particularly our potential community partners, to let us know if you'd be interested in convening on a regular basis, perhaps quarterly, so that we can create this bi-directional exchange of information, at least, for the part of the puzzle that's the mental health service line at UCSF, and get some guidance, which we're about to do in this breakout session too, mind you, but an ongoing place that would be much appreciated for us to bounce ideas back and forth and continue this discussion. And similarly, I think from the Children's Hospital, Matt Cook has suggested that we could do some quarterly regular communications out to the community about what's going on, updates, so that people remain informed.
Jennifer, I'm going to give you the last word on our panel today. Any final thoughts?
In addition to creating the advisory committee for mental health specifically, because just to reiterate how important it has been for us to actually have feedback from the people who utilize our service on whatever side of that service they may be utilizing it, that's the best way for us to get it right going forward and to make sure that we're really tapping into what has to happen. We also really want to make a lot more movement into integrated health so that we are there and present in the places at the front and not always sitting back in reaction from what historically specialty mental health has been, so that we're really beginning to touch from the place of one team coming together and also being able to get people before they really truly get too late.
I want to thank all the panelists for your time today, your great ideas. There's also a lot of great ideas that are popping up in the chat. And as we move to breakout sessions, let's pick up some of those great ideas. What we've talked about here from an advisory group at the hospital level to really thinking about de-siloing and working collaboratively as a continuing practice, and also lift up some really specific ideas that we're starting to see in the chat around, like, what if we use the Find Connect desk? I'll put another one on the table. How about the UCSF PEARLS screening, a new ACEs screening tool that actually is Medi-Cal billable, that it hasn't yet been scaled across even Alameda County systems. So there are lots of great ideas that you all have and that we've heard on the panels today and in the previous series. So now, as I hand it back to Dana, we're going to be getting into breakout rooms and having this opportunity to deep dive with each other and think about how are we going to prioritize the many, many ideas that are coming out, and how will we continue to move this work forward. So thanks to all of you. What an exciting conversation.
I love all of those ideas. I just want to say a big yes to everything that's in the chat, and thank you so much for the panel. Anda, would you like me to describe the breakout rooms, or should I hand over the breakout discussion to you?
I can give some instructions here. Thank you so much, Melanie, and all of our panelists and our system leaders. I really appreciate your engagement and leadership. So this is perfect. It's set us up for really thinking through for the piece. Yes, no one owns the problems or the solution in this realm, and I guess what are we going to prioritize for the piece we own to improve? Because we're all really driven and committed to improving care. So, and I do want to spotlight, and we started the series with really highlighting some of these bright spots that we have in our system and the innovative programs that people have developed and individuals and leaders in our system have developed. So I wanted people to hold that too, because like when something's working, how do we grow that and lift that up? And I saw in the chat some examples of things that are working really well. So, based on what we've heard today, based on what we've heard in the prior two sessions, and I'll remind people of the Jamboard summary and the breakout session summaries that we have from the first two sessions that we presented earlier. The question is, what should we prioritize in the next 1 to 3 years in order to act on improving child and adolescent wellness and mental health. And you ask yourself, like, if we get some funding, if we could get some funding, what would we do with it? So we will be randomly broken up into a small group that has a facilitator and a note taker. In the chat, there will be a link to the breakout group documents. Please, in that document, go down to your breakout group to document. So it's all in one document. There, you don't have your own specific document, so just get to your right breakout group in that document. Each participant, we're going to have free individual generation of ideas where you can place them in the pick chart, and I'll show you the pick chart on the next slide and what that is. And the facilitator and each of you in your group will review all the ideas after the first 10-minute brainstorm that you have. And then each person in the small group will vote on their top 3 ideas by marking an X next to their top 3 ideas that people have put on the pick chart. And we'll send out a summary of the top ideas after today's session. So thank you for pulling up the pick chart. So the pick chart is, PIC stands for possible, implement, challenge, and kiss goodbye. So on the y-axis, you'll see from low to high impact, and on the x-axis, you see low to high effort. So the green box is in the upper left, and that's kind of the best because it's execute right away, it's high impact, low effort. In contrast, in the bottom right, you see, focus on other ideas because that's low impact, high effort. And then the yellow area is a challenge, and maybe we can think of ways to reach the same impact with less effort. That is something that takes has high impact but high effort. And then in the bottom left, you see the low impact, low effort, so kind of what people might call low-hanging fruit. And ways to think about that is, can you increase the impact so that it goes into the green zone? And you'll see, like I have examples there, there's ideas, and people will be putting little X's so that the group can identify what their priorities are. So the instructions are also in the document, just in case you forget. And I think we can go into our small groups. If there's anything that needs to be clarified, please put them in the chat.
Hello, everybody. This is George Weiss. I think people are still coming back into the room. So I'm just going to give a minute or two, and I get the honor of providing some closing remarks. So welcome back into the main room. Thank you all for your incredible participation throughout. Cassandra, can you just let me know when we've got everybody back in? Looks like we are, okay, we're good to go. All righty, well, thank you all. I am George Weiss. I'm the Vice President of Operations for the Benioff Children's Hospitals, and a community organizer at my roots. So today was like soul food for me to understand how groups can come together to problem solve and access our collective power to come up with a better solution around an issue that's very complex. Business, you see on the screen a QR code. Please scan it. Please provide your information so that you can continue to be engaged in this work, because we started a conversation that we need to continue. Secondarily, in the chat is a link to a survey. Please provide the feedback. This has been really rich and really robust. And I just am really jazzed about the working group breakout and the deeper level of conversation that we started to get into around how our systems can come together to support better outcomes for our children and their families. So I'm just gonna relay back some of the things that I heard. I want to ground in what Sauntoy said. Our children are well. Our children are well, and we need to think about how we address the context and structures that impact their well-being. The second thing that I heard is that in our current model, which is about attending to the outcomes of those structures, we have this array or range of services that work under mental health services in multiple contexts with some examples where there's amplified benefit because there was an interconnection of caregivers. And I think that's powerful. I think it's also powerful to note that those different caregivers are caring for children as members, as students, as patients, as clients, and or a child. And that's interesting to hold. There are a large number of very different critical microsystems with different approaches and very specialized language. So if I'm navigating, if I move from one school district to the other school district, I have to learn the language of that school district for my family. How do we incentivize and cultivate more strategic collective impact? So now I think about the sea is vast and my boat is so small because we have a demand that's growing and it's outpacing my capacity. So how do we then reconnect with the idea that what we might think of as non-traditional is actually traditional? So how do we harness community wisdom? How do we take Melanie's great words around cross-system conversations and collaborations are essential so that we can have innovative models for collective impact? So all of this says we have more work to do together, right? How do we now kind of get from this level down a few levels so that we can begin to think about those interconnections, and how do we weave solutions that we might be able to pilot, find best practices and spread so that we can take our collective resources, access the resources that are coming, and do better by the children in this region. So I'm very inspired by our future because of this conversation, because of each of you. I thank you for the time and energy that you put into this series. And more importantly, I thank you for your collaborative work as we move forward so that we can actually harness some of these ideas for great outcomes. So thank you very much, and I hope you have a fantastic day.
Thank you so much, George. I just want to put a plug. So that survey is not just a regular survey. It's like 3 questions, very short, and it will give you the opportunity to tell us how you want to engage, from like a newsletter quarterly to actually being on a committee. So please take the time to just click on that link quickly and fill it out. And just appreciate everyone for hanging in there on this beautiful afternoon. Just grateful. Thanks so much.